I want to leave the microphone to the presenter for this special edition. Before that, one or two ground rules, please. It would be nice to mute your mics, especially if you are not going to speak. And we leave questions and answers till the end of the presentation. You can, in any case, put any issue you have in the chat box that is open and functional, and then so we can listen seamlessly. We request that each participant puts off his or her mic, mutes his or her mic, except of course the presenter. Have the presentation on this special edition. Thank you.
Okay. Good evening, everyone.
Good evening, ma.
Okay.
Yes, good evening.
Okay. So let me stand on existing protocol. I'm going to share my slide and let me know when you can see my slide. Can you see my slide?
Yes.
Okay. Okay, so today we are going to be looking at cervical cancer overview. I'm so happy that today I'm going to be speaking to pharmacists. It's easier to talk to medical professionals than when we go to communities to talk about cervical cancer. I'm the founder of Pink Health Foundation. So I'm so glad to, at least for the first time, use some medical jargons when I'm talking to my audience. So as we go ahead, I'll make a lot of assumptions while we go ahead. If there is any question, we're all learning. So if there is any question you have, you can pen them down as the moderator said. Okay, so we hit the ground. Okay, first of all, we look at the burden of cervical cancer. Is actually the second leading cause of cancer death among women. So globally, cervical cancer accounts for about 300,000 deaths annually, and there are always 530,000 new cases, and these numbers are underreported. In Nigeria, there is an estimated 12,075 women that are diagnosed annually, and 7,968 died from the disease. This is just one in 1 year. Okay, sometimes we wonder why the disparity. If we take a look at this picture, you look at the position of Africa in this picture, you see that the most incidence of cervical cancer cases are more in underdeveloped countries than the developed countries. And if you look at mortality rate of cervical cancer, you still see that in underdeveloped country or developing countries, there are more cases of cervical cancer. Most times we wonder, why do we have these disparities? First of all, lack of wide-scale and effective prevention efforts, poor vaccination uptake, and lack of early diagnosis. because in developed climes, most of them do have health insurance. And having health insurance, they are entitled to health screening, monthly checks, where you go to hospital and you get screened for some ailments, especially the preventive ones. But in Nigeria, we have out of pocket, the highest mode of health financing is out of pocket payment. And most times it discourages people from going for annual checks. So that is why you notice this disparity in more underdeveloped or developing countries when it comes to the scourge of cancers or other preventable diseases. So we move ahead. We look at the natural history of cervical cancer. So there's a human papilloma virus, that's the HPV. They are the major cause of cervical cancer.
Yeah, presenter, sorry to interrupt you.
There
Can
are
you
many
press the
types of HPV. We have
slideshow, please? Sorry. Can you press the slideshow so we can see your screen?
okay. Can you see my screen now?
Yes, better. Thank you.
Better now. Okay. Okay, so we are saying that the group of viruses, the human papilloma viruses, they are the major cause of cervical cancer. And we have over 100 types of HPV, but we have the ones we call the high-risk ones and the one we call the low-risk ones. Majorly, type 16 and 18, they cause more than 70% of cervical cancer and the precancerous lesions. Again, when you look at HPV, is actually the most common STI virus worldwide, and it can affect both men and women. 4 out of 5 sexually active people will have HPV infection at least once in their lifetimes. The HPV affects the epithelium of the skin and mucous membrane and can spread through skin. It can affect the vulva, cervix, vagina, the anus. Can you mute, please? It can also affect the
The speaker, can you unmute? The speaker, can you unmute and continue, please? The speaker, can you unmute and continue?
Okay. Can you hear me now?
Yes, we can hear you now, please.
Okay, I think I have to remove it in slideshow. Can you see my screen?
Give it a slideshow.
Yes, we can see your screen.
Okay. I don't know where I got cut off. I said HPV in men. HPV type 6 and 11 can cause genital warts. So men can also get HPV. Then we are saying that nearly all cervical cancer are caused by HPV, but HPV does not always cause cervical cancer. There could be other predisposing factor. When we look at pathogenesis of cancer, cancer can spread. Malignant cancer can spread to any organ of the body. So it's not only HPV cause the major part of the major proportion of cervical cancer, but somebody else can get malignant cancer that can reach the cervix. So we are saying that 90% of HPV infections clear without any intervention within 2 years. So it's not everyone that gets this HPV that goes down with cervical cancer. But in 10% of women, HPV infection can persist and lead to cancerous lesions. And at least 10% of these cases of precancerous lesions can progress to invasive cancer. Because HPV is a slow disease, most times it can stay in the body for between 15 to 20 years before it can develop into cancer. In fact, I think it's one of the most merciful cancer because it has stages. When it comes, it stays as a pre-cancer stage. If no intervention occurs, it can progress to an invasive cancer. We look at the risk factors of HPV, stroke, cervical cancer. One, early initiation of sexual activity. That is why we always target young children for vaccination, because when you do vaccinate them on time before the debut of sexual activity, they can have better protection. Then when people that have multiple sexual partners, multiparity, co-infection with other STIs, which can affect immune system, making somebody unable to clear the virus. Then we have a mother or sister, that's the family history of cancer. Then smoking cigarettes, immunosuppression, and so on. Then we look at the natural history of cervical cancer. You have the persistent and chronic HPV infection, which stays progresses to precancerous lesion. When somebody gets this HPV, it can develop and start causing precancer changes around the cervix. Then this precancer cervix will stay like 10 to 20 years and develop into an invasive cervical cancer. So we are saying that cervical cancer is nearly 100% preventable with screening and treatment. Assuming a woman screens for cervical cancer every 3 to 5 years till the age of 70 years, it can dictate these precancer changes and either use a cryotherapy or lip therapy to clear off before they develop into an invasive cancer. So we look at the signs of cervical and symptoms of cervical cancer. Most times, we intentionally avoid mentioning the signs and symptoms of cervical cancer because most of the signs of cervical cancer overlap with signs and symptoms of other disease. And we don't advise women to sit down and wait till they get these signs before they go for annual screening. But we have to mention some of them. One is abnormal vaginal bleeding, bleeding after having sex, postmenopausal bleeding, and heavy bleeding in between period. Abnormal vaginal discharge, that is a discharge which is different from the normal foul smelling or pale, watery or pink or brown, no matter the color. Discomfort in the back, leg, pelvis, abdomen, or after having sex, swelling on one leg, but some of these symptoms are vague and not unique to cervical cancer. So we look at cervical cancer screening. Normally, we have three modes of prevention of cervical cancer. We have the primary prevention, we have the secondary, and we have the tertiary prevention. For primary prevention, is usually targeted at girls between 9 to 13 years through HPV vaccination, health information, warnings about tobacco use, sexuality education tailored to age and culture, condom promotion provision for those engaged in sexual activity, male circumcision. Then we also have the secondary prevention targeted at women greater than above 30 years of age. We talk about screening and treatment as needed. You can use screen and treat, or with low cost, like using a VIA, that's visual inspection with acetic acid, or visual inspection with glucosiodine. You can also screen using HPV testing, or you can also use a pap smear. Then we have the tertiary prevention, which is where you are trying to treat the invasive cancer. You can use ablative surgery, radiotherapy, or chemotherapy. So we look at the primary prevention, which is HPV vaccination. So we talk about the vaccine. Normally, HPV vaccine is very safe. That is why when there is vaccine hesitancy, we advise pharmacists, especially the community pharmacists, to engage with patients and tell them, or their clients, and tell them that these vaccines are very safe, that every insinuation, there is no truth behind those insinuations. So the only side effect to these vaccines are actually redness at the site of the injection and orthostatic hypotension. We always advise patients to sit down while they're receiving HPV vaccine, or lie down while they're taking it. Don't allow them to stand up when they are giving them HPV vaccine to avoid orthostatic hypotension. So HPV vaccination provides safe, effective, and lasting protection against HPV infection that mostly cause cervical cancer. The vaccine series is more effective when given before a person is exposed to the virus, and the vaccine is safe. So the vaccine now, currently, we have, initially we had two types of vaccine, the Gardasil 4 and the Cervarix. Now, currently in US, it has been phased out because I was opportune to work at as an IT at Maricopa Department of Public Health in US, where they have a vaccination clinic. So that was 2017. I found out that they were no more using Gardasil 4 and the Cervarix. There they use Gardasil 9, and that Gardasil 9 is approved for young girls and young boys, because when you're entering the secondary school, you have to show your vaccination record. So when they come to the clinic to update their vaccination record, we always advise them to get this vaccine, Gardasil 9. But I don't know whether it's the cost. I don't know about people that work in the hospital. I don't know whether we have Gardasil 9 in Nigeria now. I know we are still using Gardasil 4 and Cervarix. So the difference is the range of HPV these vaccines can clear or protect against. So for the Gardasil 9, they can cover HPV 6 and 11, which cause genital wart. They also cover 16, 18, 31, 33, 45, 52, and 58. And they can be given to boys and girls. But in Nigeria, we had Gardasil 4. Gardasil 4 by Merck can protect against HPV type 16 and 18, which cause cervical cancer. They can also protect against type 6 and 11, which cause genital wart. We call them the quadrivalent vaccine. We also have the Cervarix by GSK, which is a bivalent vaccine. It can protect against HPV type 16 and 18, which cause cervical cancer. All these vaccines are licensed, and but here we pay out of pocket. But for children below, from age 9 to 15, it's free of charge in most primary healthcare facilities. All the HPV vaccine protect against the major types of HPV, that's 16 and 18, which cause most cases of cervical cancer. So we look at the dosing. For children aged 11 to 12 years of age, in Nigeria, in fact, below 15 years of age, from 9 to 12 years, we give them 2 doses within 12 months. HPV vaccine can be given starting at age of 9. Doses are, you can use 3 doses. If you give a child HPV vaccine when the child has attained her 15th year birthday, you have to give 3 doses. But if a child has not reached 15 years, you have to give 2 doses. But if a child is not 15 years, but has some other immunosuppressive ailments like HIV, that child has to get 3 doses. Then the first dose, you give it at 9. You can start at 9, but CDC approved 11 to 12. But you can start giving the first dose at 9 years. Then 6 to 12 months after the first dose, you repeat the second dose. If a child is above this age range, you give 3 doses. Then again, WHO also approved this vaccine for adolescents, girls, age 15 to 26 years. But from 15 to 26 years, you give them 3 doses of the vaccine. And these doses are given over 6 months. Then, above this age, that is where the politics is. People with we have talked about that. People older than 26 years, vaccination is not recommended for everyone older than 26 years of age. But there is one study that said, just one research by Patricia, I can't remember her surname, that said that adults between age 27 to 45 years can also get this vaccine. But if you get it when you're beyond 15 years, you must still go for your screening every 3 years. So we look at the secondary prevention. This is where we are talking about the screening. There are 3 types of screening. You can use a cervical cytology, that's the pap smear. You can use visual inspection with acetic acid. In fact, away from Nigeria, nobody knows what VIA is, but WHO approved VIA, visual inspection with acetic acid, or visual inspection with Lugos iodine. They approve it for low-cost setting because if you're telling a local woman to cough out about 15 to 20,000 for pap smear, it might not be feasible. So we advise people to, in fact, we always advise people to go for VIA because we prefer VIA from our outreaches. If a doctor is doing VIA or if a midwife is doing VIA, when you open the cervix, apart from looking out for changes, for precancerous changes, you can also, sometimes they also see some other things that might require further examination, people with infection, some other even forms of cancer or polyps. By visual inspection, these diseases can also be identified. Then we also have another test, the HPV testing for high-risk HPV types. Then there's another program we call the see and treat method. This is where you do a VIA on the spot, because when you do a VIA, just involve applying a glacial acetic acid. You leave it for 5 to 10 minutes and look for the acetyl white changes at the squamocolumnar junction. That is the junction at the cervix where the columnar tissues meet the squamous tissue. That is the point where these cancers start. So when you apply the acetic acid, when you open the cervix with a speculum, you apply the glacial acetic acid and wait for that acetyl white. If there is acetyl white, then we can now look at the spread and see if the woman is either positive or weakly positive, or the woman might need further examination. Then if from the acetyl white, whoever that is doing the test can also assess if a woman qualifies for cryotherapy or thermoablation therapy. Cryotherapy is where they freeze out these precancerous changes. They just freeze it out and clear the precancerous changes and everything gets cleared out. But thermoablation is where they apply heat. Most women prefer to use a cryotherapy. So we look at the target age group for the screening. The screening usually starts from 25 to 49 years. But before we screen, we usually get information on the sexuality or sexual debits. You don't screen somebody who is a virgin. Just using the speculum to open might disvirgin that person. So you must do this. But in fact, if the person is a virgin, why do you even need to screen? Then we have HPV testing is also recommended as the primary screening method for women. When women are above 30 years old, we recommend HPV testing. Then if HPV testing is not available, then VIA is recommended as the primary screening method. We look at the algorithm for the screening test. you first of all ask the client. If the client is below 30 years, we can go for pap smear or VIA or VILI. But if the client is between 30 years to 49 years, you check if HPV test is available, then you do HPV testing and follow the algorithm. If HPV test is not available, you can use VIA. So this is just a summary of the algorithm that's the protocol for HPV test. If you do HPV test and it's negative, you have to rescreen the person after a minimum interval of 5 years. In fact, between 3 to 5 years. But if it's positive, you determine the eligibility for cryotherapy and rule out cervical cancer using visual inspection. When you do HPV test and it's positive that this person has these HPVs that can cause cervical cancer, you still have to open the person up to check the extent of the precancerous changes. If the precancerous changes have spread deeper into the cervix, you see that this person may not qualify for cryotherapy, so you refer for further tests. So we are saying that, okay, so we determine if the person is positive, you still use VIA, then determine the eligibility for cryotherapy, and then if the person is qualified, you treat with cryotherapy, that's the freezing. Then you also do a follow-up after 1 year. If the person is not eligible for cryotherapy, you can use LEAP. Then if you're suspecting cancer, you can refer for further diagnosis like the biopsy and other protocols. So the same way for the VIA, if the VIA is negative, if you do HPV test and is negative, just the same process applies here. Then there's another one. Most times, some patient doesn't want you to open them up and collect sample for either HPV testing or pap smear. Sometimes researchers have shown that some women would prefer, depending on the culture or, I don't know, convenience, they prefer to do self-sampling. There are some studies on this self-sampling. This is where women are given the swab to collect the swab, return the swab to maybe the pharmacy, who transports it to the lab, and the lab tests it and return the result to the pharmacy. This is a public health program that any pharmacist can even implement in a community pharmacy. If you decide that your community pharmacy will be a spot for collection of HPV testing, you give them the swab, teach them how to use the swab in a right way, collect the swab, return it to you, and you do the test and provide the result for them. So we are saying that HPV self-testing is a way of improving early detection of these cancers. Okay, so for women that use VIA, that's visual inspection with acetic acid, we use it for women between 25 to 49 years, like I said earlier. Women that do this every 5 years are most unlikely to present with invasive cancer because you keep on checking your cervix. If there's any pre-cancer that will last like 10 to 15 years before it gets to invasive cancer, through annual VIA screening, open and see, you can find these things out. Then, approximately 70% of invasive cervical cancer occurs in women above 45 years. Then for women who are greater than 50 years, provider may be unable to visualize the squamonocolumnar junction. That is actually the junction at the cervix where these cancers can occur. So most times we recommend pap smear for these women. Then HIV positive women should be screened every year, starting from the age of 25 and at any age of diagnosis of HIV, because there could be co-infection with HPV. So screening, we'll look at the screening coverage. Since most invasive cervical cancer occurs in unscreened women, reaching these women with preventive services will have great impact on reducing the incidence and mortality of cervical cancer. Unnecessary rescreening and screening those outside the target group will increase the cost without having an impact on the general public. So, in brief, that is all we have for today. Thank you for listening.
Thank you very much, the presenter, for this wonderful presentation, which I consider from my end to be very educative, informative, and actually stimulating. We need to start looking into these areas as pharmacists, community pharmacists, hospital pharmacists, and all that. So thank you once again. Please, may we now call for comments? We know this topic is general overview of cervical cancer. So we may not actually go beyond knowing what cervical cancer is and what we can do when we want to prevent it. So the therapeutics and the other things are not actually considered here, but they can be topics for future discussion. So may I call on any person with questions to raise their hand or open mic and speak to us. Thank you very much, everyone. Thank you for our participation. Questions, comments, remarks, clarifications. This is the time for it.
Okay, can I say something?
Go ahead, please.
Okay. Good evening, everyone. I'm glad that I am part of this tonight's presentation.
It's breaking.
There is a
the
break in network. Please, can you go on if you are still on?
Well. Thank you so much, our dear president.
I guess the person that was commenting had a.
I think she's having some network glitches. Hi.
Okay, please, I don't know, can I make some comments? Huh?
Okay, go.
Hello?
We can hear you.
Okay, my name is Pharmacist Charles Albert. I don't know if I'm audible enough.
Yes, we can hear you.
Okay, at first I want to congratulate the presenter, even though I logged in a bit late. But I think I was able to pick some vital things she said. You know, this very topic has been a very controversial topic. It has been controversial in the sense that some healthcare practitioners have been able to come up with some vital researches concerning the side effects, and then also we're able also to point out some politics behind. Sorry if I'm sounding a bit controversial, but I think we as professionals at times we have to also dare to, be open-minded and also research, of which I've done that. There's one paper published in Kenya about the side effect of this drug, of this vaccine, sorry. The presenter said something about uh, uh, about a virgin, as in about if I think when she was saying something about the screening, he said that there's no need of screening a virgin, which is very
Yeah.
true. Then the question then is that why now giving the vaccine to 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 that class of individual, which we 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 know that this thing is an STD thing, and probably majorly through sex. So young babies and girls that have not indulged in sexual activity, while loading them up with this vaccine. In fact, what I saw when I did a little research about the vaccine, it was so very very enormous. I know that some people also have come up to refute those claims and saying that those things they are this and that they are not true, that those side effects. But just if we can put things A to B and all that, someone that have not indulged on sexual activity, the risk of having HPV is very, very minimal. Okay, we now accept that there's no need of
Hey, I think we lost him.
Hello, I'm still here.
He's still on. Please, go on and
You can hear
possibly
you.
summarize what you want to say.
Okay, I think I've made my point. I've made it's just a kind of concern, you know, it's just a kind of concern where we can, any person can decide to look up different publications of this side effect. So it now left us with a moral question to us individually as a pharmacist. Is it really advisable to start advising, maybe as a community practice, as a community pharmacist practitioner, to advise your patient or your guy or people that are related to you, their girl should go and take this vaccine? I think that question should be left for each and every one of us. I think I need a more clarification in case if anyone has a different opinion on that.
Okay, thank you so much, sir. Okay, first of all, we look at hierarchy of evidence. When we are looking at publications, we have to, when we know that when it comes to hierarchy of evidence, the systematic review will give you the highest evidence for any question you're asking. So most times we try to, when we are looking up, try to look up on systematic reviews on possible side effects of these vaccines. And again, we are saying that there's no drug that doesn't have a side effect. But from systematic review, have we recorded any? Then again, we're looking at the immunogenicity of this vaccine. And from the clinical trials, they found out that these vaccines are more effective when taken before sexual debut. And in most times, some girls become sexually active from maybe when they're in secondary school, some 16 years, some 18 years, some 20 years. Okay, now, if we're delaying these vaccines and hoping that we give them these vaccines when they are old enough, by that point when they are old enough, it can't say exactly when they will become sexually active. But we are assuming that between the age of 9 to 15 years, these girls in normal climb may not have been sexually active. And that is the point where you give this vaccine to get the maximum effect. I've seen people with, in fact, I've lost like 3 persons to cervical cancer, and I know their regret. I started up a foundation, Pink Health Foundation, because of my friend I lost to cervical cancer. And I know her regret. What if she had taken these vaccines earlier? Why is it that reports again about the side effects of these vaccines are in Africa, more commonly in Africa. Then again, why is it that when people were paying out of pocket to get these vaccines, nobody talked about them? Back 2015, when people come, ask for this vaccine, and we source for these vaccines, nobody talks about the side effects. Why now that the vaccines were made free? So these are also the questions. I'm not disputing.
Hello, are we still on? The presenter, please. Are you having network challenge? The presenter, please. I guess we're getting challenged at the network level. Okay, so in the last comment and the questions, and the presenter was trying to conclude her remarks over that matter. If anybody has, while we wait for her to reconnect, if anybody has any other comment, please, can we take them, or even questions? There is one question here I see in the chat box. I read it as it is. Thanks so much for this wonderful presentation, Ma. Can
Thank
we please get a soft copy?
Yes,
I think that's the answer. Hello?
I got
Okay,
cut off by
you are back on now?
Yes, I'm here. I don't know whether you
Please.
heard me.
We had the much to a large extent, just when you were trying to conclude about why are the vaccine side effects
Okay.
from now.
Okay, let me continue from there.
Yes.
So I'm saying that I remember back before I joined academics, my community pharmacy back 2014, women were buying these vaccines for their young daughters, giving their young daughter these vaccines. Nobody complained about this vaccine. Nobody talked about them. It was not on social media. And they continued, and other countries have been giving these vaccines. Nobody complained till these vaccines were made free of charge. That was where hell was let loose, and people started talking about the infertility side effects. In research, we understand that if we don't have evidence for anything we are saying, we should not talk about it. And the highest hierarchy of evidence is a systematic review. So most times when people come and say, okay, this causes this, we'll be like, do you have a systematic review or a clinical trial, randomized control trial to prove whatever you're saying? So I believe that we can go into more research. We can join hands, carry out one systematic review on possible side effects of these cervical cancer vaccine, HPV vaccines, and actually know if how many years down the lane have we noticed any side effect to these vaccines? I don't know whether I answered you, sir.
Yeah, I think that one has addressed that issue raised by King Charles. King Charles, okay. I hope that is also true with you.
Yes, almost, sir. But let me just add so much. I appreciate you.
Thank you.
You know what? Like when we talk about the side effects of vaccines are not like OTC drugs that the side effects are quickly noticed, or some of those other drugs. These are things that take years and years and years. And probably when when the vaccine started rolling out and people started taking it, probably it might not have suffered. But what I'm soliciting and what I would rather, though is a personal opinion, though I would have said if the screening, the pharmacists, we as a pharmacy, we're supposed to champion and preach about the screening more than the vaccine, because cyst early dictation and all those things can easily be treated. And the variant of the virus that even translates to HPV is just about 2 of the variants, and which is very, very common
I
to
lost you.
women.
So
Hello?
we thank you for that comment, King Charles. There are
Okay.
many hands raised up here. Can we please hear others? Hello, King Charles. All right. So before that, I was saying there was a comment on the chat box. Somebody is saying, thanks so much for this wonderful presentation, ma. Can we please get a soft copy? I think that the answer to that question will come from the Educational Committee of CPAN National. I believe there's a way we can share these slides for the participants. That's the answer from here. Educational Committee, please, anything to add to that? Okay,
It will be shared.
Two hands.
It will be shared.
Okay, it will be shared. Okay, thank you so very much. Please, let's recognize the hands that are raised here. The first hand I saw was A0. Please, A0, you have the microphone now.
Thank you very much. I want to thank the presenter for a wonderful presentation.
Thank you.
I just want to refer to the issue raised by the last speaker who raised the question of side effects and the speaker's comment on research. I'm happy that the presenter also have a foundation. Going forward, I think especially those of us in academia, issues like these are things we need to pay close attention to in terms of designing studies to evaluate these claims. Vaccines came up, there were no issues. But the essence of post-market surveillance is to pick whatever was not documented initially. And over the years, things that were not documented before can come up. So I want to appeal to the presenter being in the academia and having a foundation. I know there are loads and loads of research grants for cancer-based studies. So it would be nice for us to have original homemade research that will be published to either support or disprove these claims, so that for purpose of scientific discussions, we can then confidently say that this is the outcome of this and this study. That will carry more weight. It is time for us to lay down on their studies. We have great minds, bright minds like the presenter in our academia, in practice. It is high time we start drawing up research proposals and executing studies that can either affirm or disprove some of these claims. Thank you.
Thank you so much.
Thank you very much.
Look,
And I'm not sure there's anything to add to that. I can't agree less. The presenter, yeah, just made all the marks, all the points.
Thank you so much.
Thank you so very much.
Thank you
we
so
have
much.
another hand up here. Maureen Wafo, please. The mic is on you now. Hello, Maureen. Please unmute yourself, and you have the mic now. Your hands are raised.
She can type the question. I think her network is bad.
I think so too. So I have a question here on the chat, but let me read while we wait for her to connect. Thanks so much, Ma, for this wonderful lecture. My question is that, why is the vaccine limited to age 26 and above? And why is the vaccine very expensive? I guess
Oh.
I hope you're not working in the industry.
No.
I think this can make people to not to get the vaccine. So please, can you react to the first question of why is it limited to 26 and above?
Not above. Okay. First of all, the vaccine is approved. We're looking at the immunogenicity of the vaccine. And they found out that it's actually better and it works better when given before sexual debut. So it's actually approved from age 9 to 26. We've said it during the presentation that if you take it before 15 years, you get 2 doses. Above 15 years, you get 3 doses, but not beyond 26 years. But somebody came up with a study where they carried out a study and they found out that people above from 26 to 46 years can also get this vaccine. But the clause there is that if you get this vaccine when you're above 26 years of age, every 3 years, 3 to 5 years, you go and do screening. And when you're doing the screening and it's negative, when you clock 70 years and you keep on getting negative result, you stop screening. Why? Because assuming you're negative to HPV, and at 70 years, you get HPV, which may not be possible. If you get HPV at 70 years, HPV will stay like 20 years, going through precancerous stage to the invasive cancer stage. 20 years from 70 years is 90. You have to make the trade-off if you want to live more. So that is the approval. So I'm trying to understand your question, why we are looking at the immunogenicity when it will work better. And from clinical trials carried out, they found out that it's better given before somebody gets the vaccine, the HPV. But if you get the HPV and you get before taking this vaccine may not give you the protection. I don't know if I answered you.
From one was there, Mary. No, so I hope that takes care of your question. I don't seem to see any further hands. Please,
Yes, thank
Dr.
you.
Maureen, are you in the house?
I've been going off and off long. I don't know that somebody
You are welcome.
is
You are welcome back. You are
okay.
welcome back.
I don't know whether somebody I asked my question. I was trying to ask that I used to hear that girls even below 15 who are sexually active should not take this vaccine. I'll now ask you, if they do, what should happen?
Okay.
I really want to understand the relationship.
Okay, so basically from my experience where I worked, like I shadowed in the States. So when a girl is sexually active, we're looking at immunogenicity. And we're saying it's better taken before sexual activity. It doesn't mean that the vaccine can prevent further influx. You might have HPV and it's not 16 and 18. You can have other types of HPV. So what we're saying that if a girl is sexually active and is still below the age of 26, she will be vaccinated. But know that that particular child will start screening whenever she clocks the screening age, which is 30 years and above. So know that that child might not get the same protection somebody that is not sexually active will get. And sexual activity, that she's sexually active does not mean she has. Most times, when a child is sexually active, when they want to give the vaccine, they do HPV testing. They collect the swab sample, test for HPV. If HPV test comes negative, you vaccinate the child. Her sexual activity does not mean that she has HPV. I don't know whether I answered you, fam.
Yeah, thank you.
Okay, thank you, ma'am.
We don't seem to see any other hand up. I want to still thank the presenter for, I think answering the question, it becomes more educative than even presenting the topic. So let's see, there's no other hands that are up, and I have not seen any further questions on the chat box. That may mean we have actually dealt with this topic for this night. May I call on a national CPAN national officer in the house to pass any comment, vote of thanks, or make an announcement as may be the case, please. My co-host here, the host here is CPAN National. If you, I don't know, there's no particular name. CPAN National.
Good evening once again.
Please.
I see that our dear national chairman is off this track. He was here earlier. So on behalf of our national chairman, Dr. Joseph Maggi, I want to thank everyone that really participated in tonight's special edition. It was a short notice, but our dear presenter made it possible. So, Dr. Ifeanyi, we appreciate your effort tonight. And the moderator,
thank you.
Dr. Ifeanyi, thank you so much. Just a week,
thank you.
we're able to make this wonderful presentation. We appreciate you, man. And I want to thank everyone. And we really want you to join us in our the panel expert group. I know that we have something to give us concerning cancer, especially cervical cancer. So we'll always call on you. Thank you so much. And I want to, I don't know whether you are our member. If you are not, please, Dr. Okechukwu will tell you what to do, because we would love to have you on our platform. You are the clinical pharmacist and you have something upstairs.
Consider it done. Consider it done, man. Yes. Consider it done.
Thank you. Thank you so much. Thank you so much. So I want to join everyone that the practical meeting on Fridays are started. Let us inform our colleagues to join us next week Friday. We'll be here again. Thank you so much. Have a wonderful night's rest.
Thank you, everyone.
Thank you so very much. With that said, may I call on Queen Fasoni, please. May you lead us in a closing prayer for this special edition of our presentation. Queen, please unmute yourself and lead us in a closing prayer. Queen Fasoni. I hope she's here with us. I see her name active, yeah? Okay. MAU, if as one I know, please lead us in a closing prayer. Maureen was. Please unmute your mic and lead us in a closing prayer. MAU. Wow. This people, are you all here? Is the network giving us a beating this night? Okay. Anyone can do that, please. I'm from among us. Anyone? Yes, Queen Fashion, I can see your mic open now. Please go ahead.
Thank you very much. Let us pray. Heavenly Father, we thank you for this. We thank you for this presentation. Thank you for making it a worthwhile time. We commit everything that is discussed into your hands so that you give us the to be able to implement everything we have heard in our practice. But these are not the biggest things.
I think the network is actually dealing with us. Can we say amen to the prayer, please?
Amen.
Amen.
Amen. Thank you so very much, Queen. And let me also say good night to everyone who participated. Please have a good night rest.
Thank you.
Well done. And you too, sir. Thank you for wonderful moderation.